السلام عليكم ورحمة الله وبركاته. معكم سارة العامر، تخصص طب الجراحة ليفل 9، ليدر تيم الويبينار، ومعي زميلي صهيب عاشور ليفل 11. نرحب فيكم جميعا في ويبينار الحالات الطارئة في جراحة المخ والأعصاب الأطفال، اللي هيلقيها بإذن الله الدكتور عبدالله رمضان، الحاصل على البورد الأوروبي والعربي والسعودي في جراحة المخ والأعصاب. بداية حابين نشكر عميد كلية الطب الدكتور محمد عبد الجبار، ونائب عميد كلية الطب الدكتور سعد عسيري، ورئيس لجنة كلية الطب الدكتور محمد الشربيني، جميع أعضاء اللجنة على دعمهم وجهودهم المستمرة. بس ملاحظة، إن شاء الله الأسئلة هنستقبلها بنهاية الويبنار، تكتبونها في خانة الأسئلة. الحين نرحب فيك دكتور عبدالله رمضان، وشاكرين لك سرعة استجابتك وقبولك مشاركتنا في هذا الويبنار. تفضل دكتور، احنا جاهزين إذا أنت جاهز.
طيب، بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أحب أشكر في البداية اللجنة الأكاديمية في كلية الطب بجامعة المعرفة على هذه الدعوة، وإن شاء الله هذه المحاضرة تكون بداية لمحاضرات وأنشطة أخرى بإذن الله. طيب, so I will talk about common cases that we expected to see as a neurosurgeon emergency department. Definitely this lecture will not cover everything. However, I will try to do a generic comprehensive so we can all get use of it, inshallah. The type of cases that you may see as a pediatric neurosurgeon to differ from center to center. So if you are working in tertiary care center or secondary care center. However, in general, most of our cases that we are seeing is congenital trauma related or tumors. There is few cases of infection or cerebrovascular disease that we are encounter. Talking about congenital cases, I'm talking mainly about hydrocephalus and shunt in this lecture, inshallah. In regards to in regards to trauma, we are talking about traumatic brain injury, the different types of hematomas like epidural, subdural, and in regards to tumors, the mainly presentation to emergency, we are talking about tumors related to hydrocephalus, mass effect, or seizure. For cerebrovascular disease, the usual presentation of the patient either related to stroke, hemorrhagic or ischemic stroke, and in relation to infection, we have some aspect that we are as a neurosurgeon will be involved in meningitis, encephalitis, and in the brain abscess. So I will focus more about congenital trauma and tumors. I will give one slide talk about infection and cerebrovascular disease. So when we are talking about cerebrovascular disease, always think about something sudden, acute onset. Usually the presentation will be between hours to maximum days. And one of the common pathology we are encounter in cerebrovascular disease in pediatric is arteriovenous malformation. So the usual presentation is associated with hemorrhage, around 30 to 50%. 15% of patients, they may present with seizure. It is commonly sporadic. However, in less frequency, we saw some cases of in relation to syndromes like hereditary hemorrhagic telangiectasia, for example. The usual age of presentation is around 20 to 40s. So usually in pediatric, we saw these cases in what we call young adult or late teens. The treatment include surgical intervention with or without endovascular management, without stereotactic radiosurgery. So usually these cases should be treated in comprehensive cerebrovascular disease center, where we have a neurosurgeon, vascular neurologist, radiation oncologist, and neurointervention radiologist. So these cases should be treated in comprehensive manner. So usually we have at least two modality of treatment. Most of the cases treated with endovascular and surgery. So this is the point that I would like to stress in this kind of cases that we have to treat it in comprehensive manner. So it is not one-man show. Other pathologies we encounter is Cavernoma, which is, or cavernous malformation, which is defined as a cluster of sinusoidal vascular channel without intervening parenchyma. So it is usually well-margined, multilobulated, and this is a CT scan and MRI showing the pathology. It is located in the brainstem. This whitish color is, or hyperdense to be more practical, hyperdense lesion is a hemorrhage, which is caused by the Cavernoma. And this is the intraoperative finding. So what we will see usually is hemosiderin deposit secondary to the hemorrhage. And this will guide us to the lesion. And this is the post-op images. So usually the most common presentation is asymptomatic. So it is like an incidental finding. The next common presentation is hemorrhage. So a patient will have hemorrhage, and depending on the location, the symptoms will be. And the next presentation is in relation to seizure. So it is also one of the take-home messages that I would like to give in this regard, that Cavernoma can be radiation-induced. So a patient who receive radiation for mainly for brain tumor, they have a risk to have multiple Cavernoma. And also there is an hereditary background. So there is 3 chromosomes associated with Cavernoma. Treatment modality depend on the patient presentation. So in asymptomatic patient, we usually try to go with conservative management. And if the patient having seizure, treating him with anti-epileptic medication. However, there is a debate regarding keeping patient in anti-epileptic medication versus doing surgical intervention to cure the patient from the lesion and stop the long-term anti-epileptic medication. This depends on the patient case, and I will not go in details for that. And the second modality of treatment is surgery. Nowadays, they are talking about more modalities of treatment in Cavernoma, like using propranolol, which is not standard of care, and it is under research, and also the use of radiation. The classical teaching that radiation is not effective for Cavernoma. However, for deep-seated and lesion that is not reachable by surgical intervention, some authors they advocate for radiation therapy. However, unfortunately, the radiation effect, it has a risk for rebleeding and a risk for radiation effect itself. The third category is intracranial aneurysm. So intracranial aneurysm is in pediatric age population, usually between age of 10 and 14. In adulthood, it is more common on female gender, and in pediatric, it is more common in male. The most common location is internal carotid artery, and they have a tendency to have multiple aneurysm in pediatric. The main age for multiple aneurysm is 9 years of old, and it could be either related to familial syndrome or to infection. So mycotic aneurysm is a common pathology to see in pediatric population, especially in patients with infective endocarditis. The usual representation is subarachnoid hemorrhage as adult, and other presentations like mass effect in big aneurysm. Again, it depends about the location. Treatment, again, it is multidisciplinary team, so it should be involving the neurosurgeon and intervention radiologist. And sorry, I went through the chat. I thought there is a problem. So back to our presentation. So the usual treatment is surgical treatment plus minus endovascular therapy, and as the treatment of arteriovenous malformation, it should be a comprehensive treatment plan. Should be in a center with high volume of cases to have the best outcome. So the last category that I will talk about that we are facing on in our pediatric population is the Yamoya Disease, which is a Japanese expression to describe the haziness or like a puff of smoke. So this is what we call a puff of smoke in Yamoya Disease, which is the Yamoya vessels that created after the establishment of the disease. So defining Yamoya disease, it is a progressive stenosis of terminal branches of anterior carotid artery, and later on, due to the stenosis, the brain will try to form a collaterals, and this collaterals, unfortunately, it is pathological and weak, and the patient will be prone for ischemic infarction or hemorrhagic stroke. The most common presentation is TIA or ischemic stroke, and the age of presentation usually between 4 and 6 years of age. So treatment, either we do direct revascularization, so creating a supply for the brain from after the brain developed this progressive stenosis. So the direct one that we do anastomosis between the superficial temporal artery and middle cerebral artery, and the indirect one, which is commonly used on pediatric, we call this procedure EDAS or encephaloduroarteriosyngiosis. So what we do, we located this superficial temporal artery. We go for the frontal branch. We do a skin incision here, and we elevate the bone, and we inserted a pedicle on the brain and suture it to the dura and close. This is, we call it indirect revascularization. Okay. So now we are talking about infection. So in infection, usually we get involved, as I said earlier, regarding to meningitis to start with. So meningitis is a common disease that our colleague in neurologist and infectious disease and general pediatric taking with the infection was talking about meningitis. To start with. So we are usually involved in regard to meningitis when a patient has hydrocephalus, which is commonly encountered in TB patients. The other pathology is encephalitis, which can be very extensive, by the way. And we get involved when we ask to do a brain biopsy, mainly to have a better recognition of the pathogens, and when we have to manage a raise of intracranial pressure. So raise intracranial pressure, there is a medical management and surgical management. So when the medical management failed, we get involved as a neurosurgeon. The involvement started from insertion of external ventricular drain, which drain cerebral spinal fluid from the ventricular system to outside the body. This will help to release pressure, or doing a decompressive craniectomy. So doing a decompressive craniectomy, that's mean removing a portion of the skull to get more space for the brain, and this helps to usually to achieve a good control for intracranial pressure. The third category, we get involved in brain abscess. So brain abscess is it can happen with bacterial infection, parasite infection, can happen with fungal infection. And usually the first line of management is antibiotic. However, there is certain indication to do a surgical management of intracranial brain abscess. So in the presence of mass effect and in the presence of a neurological deficit that we think the most likely cause is a mass effect from the abscess itself, preventing herniation. And in case of that, we have doubt about the diagnosis and to facilitate the antibiotic treatment. So surgical management will decrease the duration for antibiotic. And in this case, I'm showing to you this patient has a brain abscess, and it was treated surgically, and the patient improved significantly after treatment. So usually bacterial brain abscess is manageable disease if it is managed in the correct way. It has kind of acceptable prognosis in comparison to fungal abscess. Fungal abscess, usually it is kind of terminal disease, especially it is associated with immunocompromised patients. So this few slides about the infection and cerebrovascular disease. Now we'll talk about the congenitals. So when I'm talking about congenital, I'm talking mainly about hydrocephalus and shunt problem. Shunt is the meniscectomy treatment of hydrocephalus, which I will talk about in next slides. So talking about hydrocephalus in the beginning, we can define hydrocephalus as a common disorder of cerebrospinal fluid physiology, resulting in abnormal expansion of cerebellar ventricles. So this is the ventricles that get expanded in relation to a disorder and CSF physiology. So this is what we call a very simple definition of hydrocephalus. And this is the shunt. So the shunt contains three mainly parts. This is the ventricular catheter, which will be inside the cerebral ventricle. And this is the shunt valve, which will regulate the amount of CSF that will be drained. It has multiple company, different features, but to make it simple, we have programmable valve and non-programmable valve. So programmable valve, it will be a drain in certain pressure that we can set and we can change it. And the non-programmable valve, usually they have a set of fixed pressure that cannot be changed. And this is the distal catheter. The most common location we put the distal catheter in is the peritoneum. So the most word you will hear about shunt is ventriculoperitoneal shunt or VB shunt. This is the commonest shunt insertion we do, and actually it is one of the most common operation we perform as a pediatric neurosurgeon. Other area to insert the distal catheter is pleural cavity, the atrium, and in very rare occasions we can insert it on the gallbladder or urinary bladder. So talking about hydrocephalus, to make it very simple and very easy and very logic, we can define or remark that or categorize the etiology of hydrocephalus to 3 categories. So either it is decrease in absorption, so the CSF is not absorbed in efficient way, or increase in production, so more of the reduction of CSF that it is not compensated by the absorption, or at least by obstruction of any port that the CSF going through. So this is the main etiology, and to give an example, decrease in absorption happen usually after infection or after an hemorrhage. Increase production, it is mainly related to tumors like choroid plexus tumor, and obstruction, it can be related to tumors, it can be related to also hemorrhage, it can be related to congenital malformation like aqueductal stenosis. So let's talk about common etiologies of hydrocephalus. This is one of the common etiologies that we face as pediatric neurosurgeon. So this is the germinal matrix hemorrhage. So germinal matrix hemorrhage usually occur on preterm babies. What happened that their blood vessels is not well developed, and the autoregulation pressure gradient is not well established. So they have a tendency to bleed. This bleeding, it can be graded to 4 grades. I will not talk about it in details, but in grade 3 and 4, we have in grade 3 a hemorrhage with hydrocephalus. In grade 4, we have intrabronchial hemorrhage, and in this stage, we get involved when the patient have progressive symptoms of hydrocephalus, and we have to treat it accordingly. The next category is an obstruction. So this is a tumor which is called Tactile Glioma, which is usually a benign disease. However, it is about the location, which is the level of aqueduct of Sylvius. So it causes an obstruction and then a dilatation of the lateral and the third ventricle. So how we recognize the level of stenosis? We recognize the level of stenosis because the fourth ventricle is normal. So the fourth ventricle is in normal size, and we have a dilatation of the lateral and the third ventricle. So the obstruction is aqueduct of Sylvius. Usually these patients treated with ventriculoperitoneal shunt or endoscopic third ventriculostomy. So we just treat the hydrocephalus. We don't need to treat the tumor. As I mentioned earlier, it is usually a benign tumor. Another tumor that can cause an obstruction is medulloblastoma, which is a grade 4 tumor, and it is common in pediatric age group, and usually it is involving the fourth ventricle, causing obstruction and hydrocephalus. Another cases we encounter is cases with myelomeningocele. Usually they have hydrocephalus, and majority of them, they will need a treatment for that. There is a small portion of them that they don't have hydrocephalus, or they have arrested hydrocephalus that does not need a treatment. And usually the etiology of hydrocephalus related to KRE2 malformation. I'm sorry if I am giving some unknown names to you. I think it is better if you can take notes, and it will be very helpful to search about. This is what we call adducted thumb, and it is pathognomic or a remarkable signs that we see in X-linked hydrocephalus. This is one of the etiologies that it can be diagnosed by before imaging or at the level of intrauterine period. And the last slide showing a choroid plexus tumor, which is causing two things. It is causing an obstruction at the level of foramen of Monro, and also it may also having high production of CSF that lead to hydrocephalus. So talking about signs and symptoms, for hydrocephalus, we have two different populations. So we have the infant population and older school age patient. So in infant, usually what we have is progressive increase in head circumference, usually bulging or tense fontanelle. We have dilated scalp vein. We have what we call sunset eye signs and symptoms. And usually the patient will not show like recurrent vomiting at this age. What they will usually show, they will show a progressive increase in head circumference. And this will guide or give the attention for this patient. And for young adults, usually they present, for older patient, they may present as an adult. So they may have headache, vomiting, nausea. They may have aggressive behavior or in general behavioral changes. And also one of the things that we should keep in mind, that deterioration of school performance can be also a sign of hydrocephalus or in general increase in intracranial pressure. Now we are talking about ventriculoperitoneal shunt problem or shunt problem. So to be honest, the commonest problem we encounter is an obstruction at the level of the proximal catheter. So what happens usually, there will be a debris or blood that obstructing the proximal catheter, which is inside the ventricle. And this will cause a shunt malfunction or the need for shunt revision. Other causes like, or other problem like infection. So this patient, you can see that he has a redness, which can be a sign of infection, and also he has a swelling. So swelling can also be a sign of shunt malfunction. So what happened when we insert the catheter and we have like a big opening around the catheter, the CSF will leak between the catheter and the hole. That's what happened when either we have a big hole or we have insufficient drainage of CSF. So the CSF will find his way to go outside. And also we have a problem with distal catheter exposure. So in this case, a rare case report, we have the distal catheter coming through the umbilicus. There is a case reported for a catheter going through the mouth, through the anus, through the urethra, and also it can be exposed through the skin. One of the common things that we encounter in shunt malfunction is a breakage of hardware, and the most common location in the cervical spine. So this case was for a young patient who underwent halo vest insertion. So it is an instrument that we put to do a realignment and stabilization of the cervical spine. And what happened, they noted the patient has the signs and symptoms of high ICB or related shunt malfunction. So they did a shunt series and they found that he has a breakage of the distal catheter at the level of cervical spine. So this is another take-home message for you guys. If any one of you be in the future pediatrician, neurosurgeon, pediatric neurologist, ER physician, for any patient with shunt malfunction or a doubt about shunt malfunction, please do what we call shunt series. So the shunt series will do a simple X-ray for the skull and the chest and neck and the abdomen to evaluate the hardware. Sometimes you examine the shunt and you think it is working. Even in some cases, the brain CT will not show a hydrocephalus because some patients, when they have a long-term hydrocephalus, their ventricles become stiff, so they don't really enlarge. For that, please think about doing a shunt series. Other problem with the valve. So in this case, the valve was filled with debris and hematomas as well. And the last thing is the pseudocyst. So the pseudocyst defined as a cyst that lobulated and formed around the distal catheter. This is the distal catheter in the peritoneal cavity. And sometimes it is associated with infection and sometimes it is not. So talking about trauma, we have traumatic brain injury, skull fractures, epidural hematomas, subdural hematoma, intracerebral hemorrhage, subarachnoid hemorrhage, intraventricular hemorrhage, spinal cord injury, and spine fracture. So I will talk about a few about the traumatic brain injuries, skull fracture, epidural hematoma, subdural hematoma. Intracerebral hemorrhage, it will be in conjugation with traumatic brain injury because usually it is non-surgical lesion. Usually we treated them with conservative management. And subarachnoid hemorrhage, I will not talk about in detail, but it is important to know the most common cause of subarachnoid hemorrhage is trauma, not brain aneurysm. And for intraventricular hemorrhage, usually it is associated with an extension of intracerebral hemorrhage. And for the spinal cord injury and spinal fracture, it needs a lecture by itself, so I will not talk about it in this lecture. Talking about traumatic brain injury, usually, guys, I would like to stress the point that all lesions or all emergency presentations should be treated by ABCDE. So always check about the airway, breathing, circulation, disability, and exposure. So it doesn't matter what you are encounter, what kind of problem. It is the most important issue now is the patient life. So if you have traumatic brain injury, you start with ABC. For D, we are talking about disability. We talk about the assessment of the level of consciousness, the Glasgow Coma scale, which include patient respond to pain. I'm not talking about the GCS. Let me talk about GCS. So Glasgow Coma scale involve a motor assessment. You ask the patient to move his limb, obeying command. So this is 6. And if he is not responding at all, even to painful stimuli, this is 1. And for verbal, you ask him about place and time and person. If he answers correctly, you give him 5. If he is not answering or giving any sound, you give him 1. And for eye, you see if he has a spontaneous eye movement, it is 4. And if he is not opening his eye at all, it is 1. and also include the pupillary light reflex. Unfortunately, in traumatic brain injury, we are really beyond the expectation in classification and research and everything. So this is an example of traumatic severe brain injury. So we define severe brain injury in Glasgow Coma scale of 8 and less. This is a severe. And you can see the variety of lesions that we have. So this patient have epidural hematoma, this patient have a contusion, this is having diffuse axonal injury, this is just a diffuse swelling, this is a subarachnoid hemorrhage with a part of IVH, and this is subdural hematoma. And all of these patients, they have different fate and different natural history. And so for that, it is, unfortunately, we are still beyond the expectation in management of traumatic brain injury. However, it is a message that I would like you to keep in mind, that not all severe traumatic brain injury are equal to brain death. So they are different in many ways. I will share with you this video. It is a 4-minute video of a patient with epidural hematoma. He underwent decompressive craniotomy. I would like to take this chance to that 4 minutes of break for all of us. So enjoy the video. Okay, I'm sorry for what happened. Actually, I was doing something, so just a minute. I will back to the previous one. So here we are. After elevating the bone, this is the epidural hematoma. So epidural hematoma is one of the rewarding pathologies that usually the patient, if he was taken to the surgery in the right time, he will have significant improvement. Usually the neurological deficit improve in very short time. Now what we will do is tack up suture. So what he will do, he will suture the dura to the bone. So the dead space or the space between the dura and the skull will be less. This will help to prevent reaccumulation of the hematoma. And then hemostasis and closure. And this is a drain. Okay, so we'll talk now about skull fractures. So we have two common types: linear skull fracture, which is usually one of the most common type of fracture that we encounter in emergency. Patient will have a history of fall down, and this is the result. And you can see here that it is very difficult to say if there is a skull fracture or not. So this images, I get it from a paper advocating for 3D reconstruction in all cases of skull fracture, which is usually, it doesn't cause any more radiation to the patient. It is just a program that reformat the images. And the other type is the breastscale fracture. So in the breastscale fracture, the magnitude of the trauma is more. This patient has, as you can see, hemorrhagic brain contusion, and sometimes it's associated with epidural hematoma and sometimes associated with dural injury. Usually we treat this patient conservatively unless we have a certain indication like presence of dural tear, presence of epidural hematoma, or causing a major cosmetic deformity, and relative indication when the bone thickness is in the inner table, in the inner part of the fracture is equal to the outer side of the fracture. This is an interesting kind of fracture called Bong fracture. So it is exclusive to neonate patient. So usually there is no line of fracture. It is kind of deformity. And we advocate for conservative management, and it does work sometimes. So this is a patient was managed conservatively and the deformity gone with the brain expansion. I should also stress and give you another take-home message to be careful about these kind of fractures. Sometimes you think it's okay, nothing will happen, and the patient is okay, his neurological examination is okay. So some fracture associated with significant subgalian hematoma. So this hematoma occur at the level of the skull. And the problem with this in young baby, you know, the total blood volume is usually measured in relation to body weight. So this young baby, they have low body weight. Their blood volume range between 75 to 85 ml per kg. So losing this amount of blood is very significant for them. So always ask about complete blood count when you have a patient with subgalian hematoma. In significant subgalian hematoma and young patient, we advise to admit this patient for observation, and we do a repeated CBC, and we measure the head circumference. The other issue is the leptomeningeal cyst, or what we call a growing skull fracture. So what happened after fracture, the bone did not heal well. So with CSF pulsation, the patient will have a swelling, and the bone will never heal without surgical intervention. And usually this happens when there is a dural tear which was not recognized in the first ectus. Usually the age of presentation is less than 3 years of age. So talking about epidural and subdural hematoma, it is very common pathology, very common to mix up with them. So I brought this lemon and banana to help you to differentiate between epidural and subdural hematoma. And if you are in doubt, just think that the subdural hematoma, it is inside the dura, so it will take the shape of the brain. And the epidural hematoma, it is outside the dura, so it will compress the brain. It will not take the shape of the brain. And epidural hematoma, one of my colleagues used to memorize the etiology by knowing that epidural, external carotid artery, which means middle meningeal artery injury, usually the common cause of epidural hematoma. It is associated with lucid interval. So if you have a patient with head trauma, he was okay, then suddenly deteriorated. This is what we call lucid interval. It is usually presented in 30% of actual cases, associated with skull fracture, and usually they have better prognosis with surgical intervention. In subdural hematoma, it is a bridging vein injury, and they have more high magnitude traumatic brain injury. For that, they have less favorable prognosis. I'm really sorry to take a long time from your weekend, but we are almost done after we finish tumors. So talking about tumors, the usual presentation in the emergency room will be in relation to hydrocephalus, mass effect, or seizure. So as usual, talking about each, hydrocephalus, either by, as I mentioned earlier, increase in production, like a case of choroid plexus papilloma, or an obstruction. So the pathology again is barely seen. It is tactile glioma again, very small, very indolent, and it is just about the location that cause an obstruction and hydrocephalus. And mass effect in young babies in the presence of huge lesion. Usually they have kind of accommodation. So what happened, they will have a progressive head circumference. They will not show up as symptoms like a weakness or something in the beginning. So this is a case of desmoplastic infantile astrocytoma, which is usually occur below age of 1 year. Yes, it is scary, it is huge. However, it is a benign lesion, and usually it has an excellent prognosis, doesn't need radiation or chemotherapy. What happened, the patient will present with a progressive head circumference, and signs and symptoms of high ICB, and this is the lesion we encounter after doing the imaging study. Last but not least is seizure. So if you ever encounter a question that what is the most common brain tumor associated with seizure, you have to mention these three immediately. The first one is desmoplastic embryonal neuroepithelial tumor. And to make it easy for you, it's called DNET, D-E-N-T. So DNET, dysembrioblastic neuroepithelial tumor. Usually it is below age of 20 years. It is WHO grade 1, and 90% of patients have seizure disorder as a first presentation for this kind of tumor. The next is ganglioglioma, usually involving the temporal lobe, and also it is both of them, the DENT, desmoplastic neuroepithelial tumor and ganglioglioma, they have almost the same incidence of seizures. So both of them, they are the most common cause, tumors that cause seizure. And the next one is oligodendroglioma, which is now diagnosed by molecular and genetic investigation. It is range between WHO grade 2 to WHO grade 3. I hope you enjoyed the presentation. I tried my best to make it short, to make it comprehensive, and I'm so thankful to those who make it to the end of the presentation, as you take sometimes of your weekend to attend this presentation. I wish you all the best, and I'm open for any question and for any support, any advice. This is my Twitter account. You can reach me through the direct messages. And the mic back to you, Sarah. Thank you so much.
يعطيك العافية دكتور. شكرا لك دكتور عبد الله رمضان على مشاركتك معنا وإعطانا من وقتك. طبعا الحين نستقبل الأسئلة إن شاء الله، اللي حابين تكتبونها بالشات ونقراها للدكتور. اكتبوا الأسئلة الحين. طيب دكتور، عندنا سؤال هنا. دكتور عبد الله.
ايوه.
في سؤال عندنا انه there is any test to assess the shunt malfunction or shunt failure rather than imaging?
This is a good question, and the one who asked it is very smart. So shunt malfunction cannot be diagnosed by imaging only or clinical examination only. It is kind of comprehensive assessment. So you have to have a good history about the shunt. So when it was implanted, and if there is any history of revision. Why? The longer the time, the first 2 years is the most critical period for shunt malfunction. So majority of patients who have a shunt malfunction, they will have it in the first 2 years. The second question regarding the shunt revision, the more shunt revision the patient did, unfortunately, it does mean that he may have more chances to have another revision. The second part is about the signs and symptoms of high ICB. So if you have a patient with a shunt and he has a sign and symptom of high ICB, you have to blame the shunt first. You have to do a comprehensive assessment. So what are the assessments we do for shunt malfunction? In the beginning, in the examination, we look at the shunt. So we see if there is any redness, any area of exposure, any swelling in the abdomen to indicate that the patient have like a pseudocyst. And then we examine the valve itself. So we do press the valve and see if it is pumping or not. However, please don't take the bumping of the shunt as a guarantee that the shunt is working. It is 50-50. So it may bump and the shunt is working, and it may bump and the shunt is not working. So this is another message to you guys. After doing this assessment, we have to do an fundoscopy examination to check if the presence of bubble edema. So in the presence of bubble edema and patient with the sign and symptoms of high ICB, this means the patient have a shunt problem. Either we do the fundoscopy examination by ourselves or through the ophthalmology colleague. The next level is the imaging. So the imaging, we have to do shunt series, as I mentioned, to look if there is any disconnection in the hardware. And the second thing is CT scan. So either it show the catheter is not in appropriate position, or the shunt, the ventricles are more dilated from the previous scan, or present of intraventricular hemorrhage or a lesion that obstructing the catheter. So it should be a comprehensive assessment. It is not only the images or the CT scan itself. And if you are in doubt, if you are a neurosurgeon and you are in doubt, and you extremely look to all the reasons of the patient symptoms, it is not a malpractice or wrong if you take the patient to the operating room and you check the shunt in the operating room or do a shunt revision. This may save the patient life, and if it was working and you operated him, nobody will blame you, because you save the patient life. So saving the patient life is more important than anything else. So I hope I answer your question very clear.
طيب دكتور، في سؤال بعد عندنا بالشات هنا. Is the anterior and posterior fontanelles will delayed in closure when the patient suffering from hydrocephalus?
It is an excellent question, Bender. So yes, the reason of increasing the head circumference will be the opening anterior and posterior fontanelle, and also the widely separated suture. So this will allow the patient to have a progressive increase in head circumference to accommodate the raise in intercranial pressure. So yes, Bender, the answer is yes, and it is an excellent question.
طيب دكتور، السؤال الأخير عندنا إنه is there any early sign to diagnose hydrocephalus before it's يعني became يعني in the last stages?
Yes, definitely. It depends about the patient age. So the sign and symptoms of high ICB will show up, and this will enhance the further assessment and further imaging. So usually what happens with increasing of head circumference, after surgery, after proper surgery, the head may not increase in size. But what happens is, when the patient grow up, he will accommodate that large head. It will be appropriate for his body. So usually there is a lot of time before a patient go to decompensated hydrocephalus. So especially in pediatrics, so they will show up as signs and symptoms, and they can accommodate for a long period of time. So I encounter cases like the head circumference in a patient less than 1 year, like 54 centimeter, which is I get shocked about it. the family saw the patient is having only a large head, but he is communicating with them, he is smiling, he is calm, he is not crying a lot, and they think the only problem he has a large head, so they thought it is okay. While the patient was having active hydrocephalus. So you have a long period before the patient reached to decompensate the hydrocephalus. Just pay attention to the signs and symptoms, and usually it will not be missed, inshallah.
طيب يعطيك العافية دكتور، وصلنا لنهاية الوقت. نشكركم مرة ثانية الدكتور عبد الله رمضان وحضورنا الكريم على حضوركم واستماعكم معنا. نقدر أي تعليقات، ملاحظات، اقتراحات شاركونا فيها عبر البريد الإلكتروني أو تويتر أو حسابنا بإنستغرام. ختاما بالمعرفة نسمو شاركين حضوركم جميعا.
شكرا لكم ويعطيكم العافية، مع السلامة.